So we're going to talk. The two things are really embedded, and that's the point I'll get to. Is talking about a fellowship program, but then also alongside a health partnership. And this has been forged really, and great thanks. That must be one of the first things I say, mainly to Lucy, but everyone involved, kind of in the Southwest region, who helped us with such great links in Kenya and particularly in Nanyuki to be able to hit the ground running with this kind of project. Why did it start was really, Lucy and I were talking after speaking at a conference about 4 or 5 years ago. There's such sort of energy within emergency medicine for people getting outside of A&E departments and people using those generic kind of problem solving skills, wanting to do better for wider groups of people. And we felt that there was great kind of currency there to be harnessed into focusing a little bit more on actually like a global health view, and whether we could direct many more of these trainees who had a passion to rather than perhaps everyone doing a bit of everything, could we give a more structured way of getting people more involved in kind of global health projects? And I think when you looked around at the time, as trainees were coming through, there were just all these sort of fantastic opportunities around, but it was very much the onus was on the trainee to look around, see what they could get involved with. And the variety of, if you like, time commitment, governance, support was quite variable across them all. And it came home when we were having 2 or 3 people having really different experiences in different ways, trying to achieve the same thing. And we just wondered if could we bring something a bit more into kind of core training within the deanery, and something that would not replace any of these things, but give a home and in a way to either prepare people for, return from, and just provide better contact for sort of emergency medicine trainees wanting to work in the kind of global health sphere. And so, and Chris Hook and I, there's just down in the corner there, Chris and I were both emergency medicine trainees, and we sort of went our separate ways as I tried through all these different mechanisms to maintain kind of a global health career and build one while doing core training. And Chris went off to work for the Red Cross and MSF for a number of years. And we sort of rejoined, ending up doing the same job at the end of it, and just agreed that perhaps we should almost try and find a way between those two parts, and try and find a way that people could maintain careers without having to make great sacrifice or really juggle multiple things at the same time. And, and in that, making Global EM a bit more mainstream. So the question was, what came first? And actually what we really decided was that rather than build a partnership and then try to embed a fellowship, or vice versa, we would just try and launch this at the same time and almost make the fellowship intrinsic to the health partnership and really make it run by those clinical fellows. So if we could almost look at get the needs right, get the resources right, and then actually I can just be the admin. So I'm not the superstar of the program. It's all about the fellows really. And so that partnership is really built around the relationships of those fellows and the clinical teams from both sides, in Nanyuki and Bristol. And then obviously we're hoping that we're trying to broaden that across a regional sort of basis. But Lucy was great for this, because I had much less of a sort of academic background in terms of research and things within global health and how we were going to try and assess things going forward. So I'm forever grateful for us being able to put our heads together and come up with a way of trying to sort of, if you like, simultaneously get a fellowship up and running, recruit to it, but at the same time build a partnership around that fellowship. So the two things were never really separated out. And what do our fellows do? So now they sign up to a 12-month post. What we do is we use a lot of our kind of local expertise to give them 3 really solid days of local global EM training. That's really practical. It's around a global view of various sort of diseases and specialities. It's lots of safety and governance training around volunteering abroad. And then we give them a little bit of taster around sort of career opportunities within global health. Our trust then fund for everybody to go and do the 6 days, at least one module of the Global Health Masters. Many of the fellows will often add extra modules in their own time or when they finish to then kind of complete that into another qualification. And then we have fellows doing a 7-week deployment to our fantastic colleagues at Nanyuki. And what they do is essentially embed within the team there in a non-clinical way and help work on quality improvement projects. And all the while then what we do is hopefully, because we now recruit around 9 clinical fellows a year, is that it develops a lot of our UK project work that everyone can be working on while they're here. And so they end up with a very busy year, but it's quite well structured. And they always deploy in pairs. We feel that it allows us to take on slightly more junior clinical fellows at times, as long as they're deploying with someone more experienced. They don't provide clinical care. They just, like I say, provide that kind of resource to help with training and development. And what they do really is the Nanyuki team set the agenda, and then they just provide that additional resource to get quality improvement underway. the aim is that all teaching and training is kind of collaborative and fairly equal from both sides. So they're in no way going to try and teach things, but they try and just learn and develop themselves while they're there. And one of the key things that we do by having, if you like, now we end up with an almost 12-month presence of clinical fellows, is that it just really embeds that relationship, and it means that the two departments are just sort of used to having each other around, and you can really tell that when it works, and largely 99% of the time it does, it just builds and builds the relationships between the two sides. And then what do I do? So I do all the exciting things, like get all the paperwork in order, and I get their risk assessments done, and I have standard operating procedures, and essentially just try and put everything in place so that we can really safely deploy a global health fellow in a way that really makes it effective for both sides. And I think probably the most key thing of this is we put most of our work into the project handover and the communication between the two sides around just really trying to avoid that any new clinical fellow arriving becomes like some with, almost arrives with a focus on their own exposure and their experience. We want them to be able to pretty much hit the ground running, know where they are with projects, and then slowly embed over time. And not have, particularly when we're traveling this way with UK doctors going over to Nanyuki, is not have people needing long periods to get kind of, if you like, familiarized with departments and hospitals, and try and make it as smooth as it can be, so that they just have it. And that's really where the bulk of our work goes, and sort of overseeing the projects and actually the activities of the clinical fellows. So quite labor intensive. We tend to meet with them weekly online just to check with their progress. And then we have these slightly bigger structured kind of handover meetings every 8 weeks. But lots of it was really just around sort of the hard work at the beginning of getting all those frameworks in place. And then one of the things that we feel when we talk about engaging your wider team was that actually it was really important to have the department understand what was going on in their name. And so around about twice a year, the BRI will send a small team of around 4 or 5 clinicians. They'll join the clinical fellows. Duncan from the education side at Nanyuki will help build an educational program over the week that they're there, and there'll just be a lot of mutual education. And here we have a picture just showing some of the Nanyuki team teaching the Bristol guys about sort of dehydration in children and procedural sedation. And the idea is it's great. We have a sort of, as the days go on, taking it in turns to teach each other, doing lots of training together. And I mean, it's just a sort of fantastic experience for those involved. But I think it's huge for both sides coming away really understanding what it is we're trying to do together. And so in the last 12 months, trying to think now, is this working? So in the last 12 months, we've had 7 clinical fellows deployed to Nanyuki. It's probably worth acknowledging the sort of elephant in the room of COVID. And I think the longer deployments and the lack of direct clinical work have been what's allowed us to essentially, our fellows work really, really hard to make things work and get them out. And undoubtedly, they've had shortened deployments, and they've had lots of tricky travel arrangements along the way, but all credit to them. They've had the willingness to be flexible and mean that we've maintained that contact and activity, particularly not initially in 2020, but throughout 2021. They've done really good work. So we've had national poster presentations, and really I've been willing to speak to anyone who'll listen to me for 5 minutes about the project, and we've ended up with the trust engaging to fund our first nursing fellowship, who is leaving in the next 2 weeks. We're hosting our own, if you like, Global Emergency Medicine Conference next Friday. And we've had our first 2 clinical fellows come through Truro, where we've provided, if you like, the Global EM element from Bristol. But at the same time, they've been able to do their clinical work as part of their fellowship in Truro, trying to broaden it into a Southwest partnership. And so we've been busy. And then it comes down to trying to measure success. So I think what we've really looked at so far is lots of process measures. We've tried to look at, is what we were hoping would happen happening, and is everybody happy with it? And if you look at some of the comments on the side, this is all more sort of structured feedback from the Nanyuki side. There's a lot of positive comments. When you get down to the bottom 2 or 3, they're comments from Bristol clinicians who have had experiences the other way. But I think you come to, I think what we'd all expect is that with the right governance, people have a good experience from both sides. And I guess the question for us now is, if you can measure that sort of process success, how are we starting to measure the outcome success? And is that to be focused on personal development of staff on both sides, or are we looking for, if you like, actual clinical outcomes from either team? And I think that's the great challenge. I think the easiest next step is to start looking at things like career progression and looking at the outcomes for staff and say, does this health partnership work for what is really our core activity, which is staff development? and then what we're sort of hoping, if you like, the byproduct is that you get kind of clinical development of both teams, but that is going to be much harder to pin down. As a measure of that, I just thought it was worth highlighting a few of the guys from the last few years. So Manu in the top left is someone who was admittedly a bit adrift, not sure to do what his medical career, now is applying to do emergency medicine training and wants to have an interest in global EM. Nagam in the bottom left is just taking up a post with the Red Cross, and Rasheen on the far right is taking up a post with MSF to go away this year, while Sinead at the bottom is started a project, doesn't want to travel anymore, but would like to work developing kind of access to healthcare for refugee populations within Bristol. And so I think it's an idea of sort of, we're getting clinical fellows going off not only to do interesting things, but they all remain sort of allied to our department, and they've all had this sort of good broad training before doing these things, and are perhaps going off in a better prepared way, and also have got somewhere to return to and somewhere for sort of support. And so perhaps looking at these guys, I start to feel this is hopefully what I was imagining a few years back when we were picturing what we could do for trainees from the UK side. We've published through the Royal College of Emergency Medicine, if you like, what we believe to be the sort of model for how these things should be done, partly out of a worry that would this become a recruitment tool and start to see lots of people thinking that global health was quite a good way to get kind of emergency medicine staff in and try and keep those standards high. But also the conference next week is really based around people around the country coming to talk about fellowships and try and sort of see where everyone sees them going. So I feel we're not sure we've got it right, but I think we're putting ourselves out there to invite criticism and to invite a discussion to get it right. But we've at least, I feel, laid a template down for the moment of how this might work. The nursing fellowship, so that feels like a whole extra leap, because as we've mentioned before, the funding for the actual medical fellowships comes from the fact that the trust fund 20% of the clinical fellows' time to work, and then we, if you like, utilise that for their global health activity. Nursing is a whole different ball game. We're getting there, but we've just at least had the funding for the pilot to be able to send one of our nurses out. And Sarah on the left, who's going to be our first nursing clinical fellow. I think one of the things is making the whole process really public in the department. So everyone's very supportive of her. It's very sort of high profile thing she's doing. And it just really encourages that kind of engagement from everybody. And then really what's then sprung up, which I've always hoped, is all the other activities around sort of global health that the fellowship just drives with that energy and the resource that we've got with the clinical fellows. So for instance, in 2 weeks, we're hosting our first Red Cross visit from a Ukrainian emergency department, doing if you like, a training around opening a new emergency department in the Ukraine. And I think lots of that has followed just from gaining that reputation and energy around global health activity within a specific department. So to me, lots of these things just come from having the right people around. And then again, we can just have that governance over what people are doing. It's not really a top-down global health program. It's just trying to encompass the energy and what's going on within our system. And it's hugely all about just getting our teams involved, never stopping talking to anyone who'll listen in any management meeting, any finance meeting, and from both sides. So Nanyuki here had in the local sort of Laikipia government media just a story about a recent trip, and then we will constantly try to feed back to our stakeholders about what's going on, and just try to push and push and push so everyone feels ownership of what it is we're doing. So what are we going to do next? We're going to listen and try and get people's ideas of where we take this. For me, it's really about trying to, now COVID is sort of hopefully easing, build the reciprocal opportunities. So we want to start seeing more travel in the other direction so that we can do the same training, but across different locations. But it's really around saying, if this is a good global health fellowship program, what does that really cost and what do people gain from it? And we can slightly package it up better to say, well, where can we do it elsewhere? How can we support other departments to do something similar? And also sort of, what is this? So it's a sustainable model. Is it part of a core curriculum? Is it something extra? But what does it cost and who's paying for it really? But so far on the sort of on a scrimping budget way of doing it, we've got to the stage of at least, I think, setting out that template. Lovely. So thanks very much for listening to me. I'm just going to ask Duncan to sort of come in, if that's okay. Duncan, I'm not sure if you let me just stop sharing my screen. So I'll see if so to introduce Duncan. Duncan is a pharmacist by trade, and as we talked about having huge sort of positive engagement from both sides, he is the educational lead for sort of continuing education within Nanyuki Teaching Hospital. And so Duncan's been really core to all those teaching activities that have gone on. And I think Janet's with you as well, who is our sister in charge of the emergency department. So what would be lovely, guys, really would just be if you can give us a couple of minutes of your perspective of what it's been like having those clinical fellows and how you see the partnership.
Thank you very much, Andy, for inviting us to this presentation. Yes, as you said, my name is Duncan Jao. I'm pharmacist in the Nanyuki, Kenya. And with me is Janet, the nurse, hospital nurse. So she's the emergency department nurse manager with me. And we would like to, we are most humbled for inviting us to give us a small overview of how basically the partnership has been. And as the CME coordinator, the continuous medical education coordinator in the hospital, I can say that integration of this partnership, having people from colleagues from Bristol and from Kenya, has been of much benefit to us, such that we have been able to realize gaps in our emergency department, and even by the feedback from our friends from Bristol on, for example, I can talk about rational antibiotic use, and I can also talk about situations of organophosphate poisoning and DKA. Those are some of the issues that we have been able to basically bring and come up with pathways and algorithms, so that we are able to come up with we are able to come up with pathways that will be of quality to our patients. So the experience has been good. The experience has been fantastic. A few weeks ago, we had Andy and the team in Nanyuki, and we went through simulations, and we also went through education over the week, and it was quite fantastic. So we are looking forward to this partnership onwards, and even get to learn more and get to interact more, and basically if next year we are able to measure whatever we have implemented, if we are able to come up with impact measurement tools, so that we are able to know how far we have gone. And this, I think, will be of much benefit from both sides, knowing the level of impact that this partnership has been. So thank you once again for this opportunity. I would like to give Janet a chance to talk to you guys.
Hello, everyone. My name is Janet Nyawira. At least I have an idea of some of you. I know Kerry Jones, I know Lucy. Those are the people that I've met. Then Andy Loke, who has been here. I don't think I know any other person, but anyway, thank you so much for this opportunity. I just want to appreciate each and everyone for this opportunity. And I want just to say something to assure Andy and the team, because we've been here, there are things that we've already started implementing. For example, massive hemorrhage. I can assure you, you can imagine we even have now more tourniquets, because people are embracing the idea of tourniquets. About the pediatric assessment, most people, especially the nurses and the doctors, are really assessing using the way we came up with, the way we had the assimilation. Then when it comes to poisoning, actually people in the world are asking, why don't you nowadays do gastric lavage? Because we've really changed. So I just want to assure you, people are really embracing. And I think looking, going forward or moving forward, I think whatever we are learning, we are able to embrace and move on. So I just want to say thank you so much. Thank you for everything that, for the support. Thank you so much.
Thank you guys, not only for today, but similarly, equal thanks for all you teach us and teach our clinical fellows who get amazing development from the time there. So thank you very much, and thanks Lucy for the chance to fill everyone in today. Happy to answer any questions.
Thank you so much, Andy, and thank you enormously, Janet and Duncan. That's so kind of you to join us. Andy, I think we do have 5 minutes now, but I think what we'll do, if everyone's ready, is just maybe, can you, oh no, you're off to a, sorry, my mistake, you're off to a shift, I know that. So we will take questions for the Bristol one now, and then we'll keep all the other questions, because we've got 5 minutes, we'll keep all other questions to the Q&A session at the end, but I know that Andy has to head off to work. So please do just raise a hand if you've got any questions. Andy, I know there's a few in the chat as well for you. If you've got any questions for Andy, Duncan or Janet, please just raise a hand and I can unmute you.
I'll see if I can, yeah, if you see if anyone's got a question, I'll have a look at the chat.
Great. Jen's there.
Yeah.
Hi. Sorry. Hi. Thank you so much for the talk. On me. I put the question in the chat and a comment about the nurses. I think it's amazing that we're sending nurses, and I think actually it contributes to staff retention in the long run as well, because they feel invested in. But I just had a question about other allied healthcare professionals and the possible expansion of the programme to them. That people like radiographers, they've got so much to offer as part of a package, especially in emergency medicine. I don't know if the funding extends to that. I know that's quite a broad group of people, but I just wondered if it's possible.
Yeah, I think so. So the funding is tricky when it comes to the fellowships. It's just on an ad hoc basis that we're trying to make the argument for each person as we go. But to me, the benefit of emergency care is it's truly multidisciplinary, and almost everything in like half of emergency care, like primary care, is about systems. And so the more, if you like, we actually shy away from sending many emergency medicine consultants because I don't think it's the most beneficial thing. In a sort of UK trust, I feel you sometimes have to go around each profession's group of people and convince them, and we're sort of slowly doing that. But I think what's great is we're hitting a critical point where I think people are coming to us saying, how do I get involved in this? You know, because they're seeing it spread. So it's easy for us with the people who are directly with us, like advanced nurses, advanced physios, our healthcare assistants, you know, and psychiatry and things. But it's that reach just out to those departments, like you say, like a radiographer. But yeah, I mean, like I say, we're preaching to the converted, aren't we? We know that all these benefits we're talking about are just about sharing practice, and we seem to have decided that that's worth doing across a deanery, but we somehow think it's not worth doing outside a border. So we're getting there, aren't we? Any
other questions?
So there was a question about the deanery, and
they found out that all those diseases, the hookworms infection.
Oh, maybe not a question.
Yeah. So there's a question about how the deanery see it. So we've managed so far with all our higher trainees to have it accredited as ED time when they're in the UK. But again, that's on an argument by argument basis. But we justify that they have the same thing, so they don't actually hold up their training, but they just lose the time when they're doing global health activity. And someone said about postponing until after CCT. So yeah, the thing about this is that because it's not like pre-hospital or something where there's an accredited system to get you subspecialty training. So actually, for us, you know, people just get more from it whenever they do it. So if someone wants to finish training, then come and do a fellowship. Yes, they'll have to do the bit that the trust want, the emergency medicine work, but actually they'll get loads from the Global Health Fellowship. And you know, and it's such a variety. So I've got 1 or 2 people who are almost F3 fellows this year, but actually we've got one person who's a surgeon with the Red Cross who just wants some emergency medicine experience, and I've got one sort of very experienced humanitarian who wants to sort of progress their project management skills. So we have that huge range of people involved.
I think Donald's got a question.
Yeah, great, Don. I'm a GP trainee here in the Southwest in the UK. I just wondered, during the past year, because of COVID, have you had much experience with virtual learning or virtual sharing of ideas? And going forward with everything about, the climate crisis and looking at our carbon footprint and so forth, how do you think that can develop over the years to come?
Yeah, absolutely. So when I was talking about the other projects that sprung out of things, we'd obviously been having the fellows have more physical contact with Nanyuki, but we also, with a couple of other regions, including Myanmar, run almost group online teaching. And I think I talked to Duncan about whether we start to do that between the three of us. And I think I would totally agree in that we've realised, haven't we, that lots of this can be achieved in a much less impactful way. But then I can't shake the idea of how much more progress we make from the embedded physical contact. And I think where we'll probably first look at is how necessary, say, these short trips are compared to the real return on staff embedding with each other. And so perhaps it's looking at the efficiency of it. So if Nanyuki staff are coming to Bristol or the Bristol fellows are going, just sort of making sure we're justifying those trips based on evidence. And I think we would probably be able to start demonstrating that, an embedded physical team that works together perhaps gains more than, a remote learning type system. But in what way, and then what do you do going forwards? So I totally agree that you don't throw the baby out with the bathwater and change the system, but totally acknowledge what we've learned.
Yeah, I don't know if Duncan or Janet had any thought on that, on the actual presence of people being there rather than doing a virtual partnership.
Yeah, so the impact of actual presence of colleagues from Bristol coming to Kenya is quite immense. Physical experience with our patients here in Nanyuki, and also with the staff, and also sharing of idea, real-time experience when we have situations in the emergency department, triggers a certain urge, or a certain zeal to work and get things done on time, and also realization of gaps real time. I can give an example of a situation where we had organophosphate poisoning, and we didn't have atropine, and we had one colleague, our colleague from Bristol. Is it Emmanuel? I think it's Emmanuel. And he was actually holding the patient physically for us to go and get the medication. Yeah, so, that was one of the things where we looked even in our emergency schedule, the list of drugs that we are supposed to add, and know that in case something like that happens, we are able to know that we have these medications on our emergency tray. So I can say that physical presence is quite of positive results, on our side. So thank you.
Great, and thank you so much for making the time in your busy days to come and join us this afternoon. We really appreciate that.